So this session is on small glandular proliferations, and so it'll build on some of the things that we've been talking about already. And I think I briefly showed you this earlier, thinking, I had my slides in the wrong order. But this is sort of a, the archetypal small glandular proliferation, right? It's tubular car. Can we white balance it again? Does it need white balancing or not? I think it might be better. Does it think it is? Maybe it thinks it already. Okay. All right. So tubular carcinoma, of course, is sort of the archetypal small glandular proliferation, right, that we use against which we benchmark our other ones. So tubular carcinoma, of course, small angulated glands that infiltrate through the stroma in a haphazard pattern, obviously lacking a myoepithelial cell layer. And as I had in my illustrations in the talk, sometimes tubular carcinomas will have a little bit of an elastotic stroma. So that potentially could throw you off if you're thinking about radial scar complex sclerosing lesion. But the glands tend to percolate out in between usually the ADH and low-grade DCIS, if you have any associated with it, beyond what would be in the central nidus of a radial scar or complex sclerosing lesion. So for me, that sort of extension beyond the confines. But as I was trying to sort of highlight, if you just took this core biopsy, I think you could see how it could be a mimic for a radial scar or complex sclerosing lesion, because you could sort of imagine that it's radiating out a little bit. You can sort of imagine that the glands are in the central area, and you can sort of imagine a little bit of elastosis. So I think, it's a real pitfall in terms of trying to recognize it. And also, bear in mind that the glands entrapped in a complex sclerosing lesion, it can be hard to see that at myoepithelial cell layer. It can often be quite attenuated, so that can be challenging. But looking for cytologic atypia, such as you're able to recognize it in the glands that you have, looking for ADH in the surrounding area, confirming the absence of myoepithelial cells. I don't usually think that you need immunostains on a case like this, but if it's very small and it doesn't give you that sense of infiltration beyond the sort of small central area, that's when you might want to do myoepithelial cell markers. And then here we have a little bit of atypical ductal hyperplasia associated with our tubular carcinoma here.
Yeah. Is it important, in your opinion, to exactly recognize this kind of histotype, tubular carcinoma?
So very good question. So do we call on Coreneedle biopsy the histologic type of tubular carcinoma? So the way we phrase ours is to say, within this limited sample, we always put that clause at the end of our diagnosis on Coreneedle biopsy. So for something like that, I would call it tubular carcinoma because I feel like it's so classic. I think it wouldn't be wrong to say invasive ductal carcinoma grade 1, maybe with tubular features or something like that. But for me, that has no areas that are not tubular carcinoma. So I would say tubular carcinoma, but in this limited sample, so that, if we have an excision specimen and there's not, more than 90% tubule formation like this, our surgeons, oncologists understand that that may change on excision. But I think my colleagues, some of them stick with invasive ductal carcinoma grade 1 and wait for the excision to finally classify as a tubular.
And do surgeons perform sentinel nodes?
So ours are still doing sentinel nodes with tubular carcinoma.
Even if it's small?
I think they are. Yeah, they still are. I mean, maybe in a very elderly patient, they may not if it was really small. they may not do it in that situation. But if it's a young patient, you know, a perimenopausal patient, they would certainly do it. Yeah. So this one is just a beautiful contrast with that, where we see such a lovely example of a radial scar. And I think, oops, hang on. Is that better? Where we can see the, you know, we have the whole, I think it's no, it's an excision. We have the whole lesion here. So you can see how you've got the central nidus with those entrapped glands, and really nothing extending out beyond that central nidus in terms of the small glandular elements. I mean, maybe in a couple of areas poking out a little bit, but really the small glands are confined to that central nidus with the epithelial elements radiating out so beautifully. And then, you know, so that we can diagnose easily as a radial scar. The elements within the center, as I said, if you just had this area, it can be a little bit tricky, but we look on high power, sorry, keep forgetting the condenser, and you can see that in some areas you might be able to fairly confidently recognize a myoepithelial cell layer, but it's really more the whole lobular centricity, the architectural arrangement, the fact that nothing's extending beyond. So I would not even need to do myoepithelial cell markers, because the constellation of features is that of radial scar. It's not a diagnostic dilemma, really. It's just to show you the morphologic features in contrast to tubular carcinoma. So this is a stellate mass on imaging studies. So this one, well, maybe people want to comment on what they think, if they would like.
Who wants to describe the case? Look at you. Who wants to describe the case? Okay, you're going? Okay, look.
Yeah, I mean, it's not, you haven't had a chance to preview, so.
Okay, another chance, please.
Yeah.
Okay, I see again stellate morphology.
What do we think about the stroma on low power?
Elastotic stroma.
Yeah, some elastosis, maybe some fibrosis and sclerosis as well.
Yes.
Yeah.
Maybe some foci of usual ductal hyperplasia.
Yeah, yeah. So I think that's exactly right. So I agree with you. So there's this sclerosis. There are these glands that are kind of percolating through. You know, it doesn't have that sort of nice central nidus that we just showed of the radial scar. It's more dispersed and irregular, isn't it? But it looks sort of stellate, and it looks like there's just a larger central area of fibrosis.
Yes.
And you're right to notice the usual ductal hyperplasia, because the fact that we've got sort of something benign going on, you know, in the epithelial proliferation would make me favor it not being invasive carcinoma, right? You know, if I was thinking about those glands in that sclerotic stroma being invasive carcinoma, you know, it would be unusual to have usual ductal hyperplasia as your epithelial proliferation surrounding it. But you're right, this is a really nice example of usual ductal hyperplasia. We've got the slit-like spaces. We've got the epithelial, you know, variation in nuclear size and shape. Some really nice intranuclear inclusions. Maybe I should go on higher power. Nice intranuclear inclusions. I think maybe even some, you know, there's, let's see, maybe a fibrovascular core here even as well. So yes, this, you know, this for me would be more of a kind of a complex sclerosing lesion type thing as I would sign it out. But yeah, you picked up on all the key things that would point us in the right direction. But I can tell you that, you know, working with trainees, they see something like this, they think, oh, it must be invasive carcinoma because we've got all these sort of small, crushed, irregular glands that are going through dense stroma. And, you know, sure, you should think about that. But putting it all together helps you come to the correct diagnosis. And then, you know, here we can see the myoepithelial cells around some of these glands. It's not always easy to see them around all of them. And so, you know, I think you just have to bear that in mind. And if you need to, you can do immunostains. But I would not, you know, do them in this case, because for me, the constellation of features is that of a complex sclerosing.
Maybe I would ask only deeper sections. Maybe. Only deeper section, no immunostains.
Yeah, yeah. You could do deeper sections if you wanted to. CK56 would maybe be something you could do here because it would stain the epithelial cells, and maybe in the center it would stain the myoepithelial cells.
A question.
Yeah.
I think for me, a very important clue is the very nature of the scleroelastotic tissue, which I think is so characteristic. It's like granular. It's different from the one you see in tubular carcinoma, in my mind. So when I see this, I see granules in the elastotic. That make me think always about Radial Scar or complex sclerosing lesion.
So the grayish elastotic stroma has more of a granular appearance to it. Yeah, yeah, that could be so. Yeah, and you know, that the sort of very dense pink fibrotic stroma, and I should have brought a case of carcinoma with that kind of, you can get cancers with that very dense pink sclerotic stroma, but they're the more unusual cancers, I would say. It's not, you know, not uncommon, but as I've sort of stressed, I think I would always start from a place of benign with that kind of stroma, unless it's, you know, really obvious invasive cancer. So that sort of tends to be my approach with that. Okay, this one's got a lot going on. This is a area of architectural distortion in a younger patient. So anybody want to have a go at this? What do we have essentially as kind of the main process going on here, do you think?
Who wants to describe the case? Nothing, nobody else?
What are all these nodules?
So we start with the baby pathologist. The baby resin, you know, it's a joke because she has been called baby resin by Chris Fletcher a few weeks ago.
Oh,
wow. Okay, I will say only my first impression. Maybe I'm wrong. Okay, but there is something that remember me. There are a lot of little glandular, like an adenosis.
Yeah. So that's basically, I think what we've got just as a low power impression of these areas that I've shown you, I think is sclerosing adenosis, right? So I agree. You're going to have more to discuss in a second, but I agree with you that the low power kind of scanning magnification view is of sclerosing adenosis, right? We've got these little glands, and maybe, I don't know, do I need to go on a little bit higher power for the screen? You've got lots of little glands. So there's a small glandular proliferation. They look compressed and a little attenuated, but they retain their, lobular centricity, right? They don't look like they're infiltrating out. So it doesn't look like invasive cancer, at least on this sort of scanning magnification view. All right, so it looks like sclerosing adenosis. So we would go on high power, and how would you confirm that it's just sclerosing adenosis? What would help you decide that? What do you need to see?
We see, I think that I see very well myoepithelial cells. And also the stroma is eosinophilic.
Yeah. So I mean, basically, sclerosing adenosis is kind of a low power look, right? You had well, you know, lobulocentric arrangement of small glands. There doesn't look like there's any cytologic atypia. Nothing's percolating out. On higher power, you can confirm that there are myoepithelial cells. And, you know, you may not see them around every single gland, but, you know, as long as you see some, then that's okay. So we have, this patient has adenosis. She has a lot of sclerosing adenosis. We've got some apocrine epithelium here. All right, so let's go around a little bit more and see what else we have. Lots of sclerosing adenosis. What do you think about, can you see anything on low power in this area?
Well, this area is more nodular, and I am thinking in two things. The first one in an adenomyoepithelioma.
Yeah.
And maybe it's
what about the cells within the spaces? How do they look, the cells within the?
They are more, and they have a clear cytoplasm.
They have clear cytoplasm. How would you describe the nuclei?
They are round,
yeah,
and monotonous.
Yeah, yeah. So when you've got clear cytoplasm, round monomorphic nuclei, what might we think about? I mean, adenomyoepithelioma is a thought for sure. Yeah. That could be myoepithelial cells. I think these, sorry, I'm having trouble deciding if it's in focus. Is that, I should use this screen, I guess. This screen. So,
a lobular carcinoma too.
Yeah, lobular carcinoma in situ, exactly. Now, I know we haven't had the presentation on that yet, but LCIS, and then as you start to look around, maybe you actually see some intracytoplasmic vacuoles in some of these spaces. Do we see some vacuoles? I think, you know, we might have vacuoles here, here.
Yeah.
So yes, you have to start thinking about LCIS, and I'll keep taking us around. It gets a little bit more. So how about here? So I think it starts to look a lot more like LCIS now, right?
Yeah.
And so she has LCIS involving adenosis, and it's quite extensive all around. She's got a ton of adenosis. And so, you know, for this case, one of the challenges when you have LCIS and adenosis is deciding about invasive, you know, a pitfall can be invasive carcinoma. I think what saves us here is that everything is really very lobulocentric. It really looks like a terminal duct lobular unit, sclerosing adenosis with involvement by LCIS. I think. So, and it, you know, it becomes more expansive in different areas. And then I believe there was something else on this case. Here it's much more spindly. It doesn't look like there's LCIS in that section. It's just the adenosis. Maybe some down at the bottom there. So great, good job. All right.
Be brave and ask questions.
Yeah, so that was a good one. Okay.
Okay. Sorry, in this case, did you recommend excision?
Surgical excision?
Yes.
Actually. So she had already had an excision, yeah. I mean,
maybe tomorrow.
So LCIS for adenosis, if it's classic LCIS and adenosis, they don't need that. You know, I think this patient, there was other stuff going on. I think maybe she had atypical apocrine adenosis as well or something. I forget the exact history on this patient, but for LCIS and adenosis, if you're confident that that's what it is and you have the explanation, then you don't have to have an excision if it's diagnosed on core biopsy and it's radiologically, pathologically concordant. Yeah. Another differential diagnostic consideration for small glandular proliferations. So this is a patient who had a breast mass that was excised. And you can see that mass here. Anybody want to sort of describe what we have here? well, I will. So it's essentially the same kind of process that we just had. It's sclerosing adenosis, but it's coalescing into one, big mass. And so obviously, the correlate for the imaging finding is the mass. And so something like this, you could call an area of nodular adenosis, or people might call it an adenosis tumor. Or, in some way you need to convey that the sclerosing adenosis is the correlate for the mass lesion. So I think most often we say nodular adenosis is the way I describe something like this. But again, it's just lots of little glands coalescing together, and you'll have the myoepithelial cells as well. I don't know, sometimes I feel like the nuclei in adenosis look very round and monomorphic as well. Sometimes I feel like just in benign adenosis, the nuclei look round and monomorphic. So if there's no proliferation, then I leave it at adenosis, sclerosing adenosis. Okay, this is a core needle biopsy in a patient who, let's say she's perimenopausal. Does anybody want to try this? And this one's not easy. Oh, sorry. This one's not easy. There was a differential diagnostic consideration here, dilemma. But so if we started at this end, what are people thinking? Pink.
Who wants to speak about this case?
It's very pink. I agree. So the epithelium is very pink in this case. Apocrine adenosis. Yeah, apocrine adenosis. So it looks like adenosis, I think. I agree with you, right? So it looks sort of like rounded nodules. But as was pointed out, it's very pink. And you start to look on higher power and you can see that the nuclei are larger. There's some prominent nucleoli. Maybe some variability. Here is looking very apocrine, right? So we've got some apocrine change there. But some bigger nuclei popping up and around here. So I'll tell you, does anybody have a carcinoma differential diagnosis for this? Does it remind anybody of any particular? Yeah. So actually, that's how it came in. Somebody was questioning whether it was secretory carcinoma. And I think that's, a reasonable question, right? Because secretory carcinomas can be lobulated, microcystic, it's very pink. So I think that's a reasonable consideration. But, I thought based on this sort of edge up here, made me think of adenosis. And we actually, because of the differential diagnostic consideration, did do myoepithelial cell markers, and they were present throughout, and you can actually even see myoepithelial cells just in here. If I go on higher power, maybe. You can see some myoepithelial. Oh, here I think you can see some myoepithelial cells quite nicely. But, they're not obvious. So I think it was reasonable to do immunostains to confirm that it was an adenosis was the underlying architecture. And then you have to sort of decide on atypical adenosis, apocrine adenosis or not. And I have to say, I think I have a fairly low threshold in a core needle biopsy for atypical apocrine adenosis. I think I originally sort of was thinking, well, it's not that atypical. And then, I don't know, I got a bit nervous. What do you think, Eddie? Do you think it's atypical? Yeah. So I ended up calling this atypical apocrine adenosis. She had an excision, and I think there was not much else. So there you have it. But that was something that I hadn't considered as a differential diagnostic thought for apocrine adenosis. But I can certainly see how that would occur to somebody. Yeah, and you can see there's a little bit more cytologic atypia in this core here, I think. So, for apocrine DCIS, as I was saying, I think earlier, what I look for is areas around the adenosis area and look for, you know, the cribriform pattern or micropapillary pattern or something that looks more fully developed as architectural atypia to go all the way to apocrine DCIS. Yeah, I don't know that that's been looked at. Yeah, that's a good study for you to do. It hasn't been looked at, to my knowledge. I'm not aware of it. Yeah.
Anyway, my first, sorry.
Yeah.
I always find it interesting because in apocrine DCIS, there are myoepithelial cells around. In apocrine metaplasia, there is no myoepithelium. Yeah. So I wonder if myoepithelial cells could help differentiate atypical from completely benign proliferation that paradoxically don't have myopithelium. But
yeah, it's not every case that doesn't have myopithelium, right? You think it's like every case? Yeah. Yeah, no, I've definitely had cases of like apocrine cysts or something where somebody's done immunostains, or maybe they did immunostains for another area and then they send you the case and it's like, what do we do with this? And you know, I wish they hadn't done immunostains because it looks morphologically benign. And so, but I hadn't appreciated that it was in every. Wow. Okay, so let's look at this one. Okay, actually, I'm going to show you this one. So this was an excision in a patient. So she had some sort of, I can't remember what the excision was for, but it wasn't for this. This was an incidental finding in a patient with an excision for, let's say, a papilloma. She had a papilloma, and it was in another section. So this was one of the pieces of tissue submitted. And what do people think we have going on here? It's a bit faded, but could be a hematoma, maybe. Usually with hematoma, I would expect normal sort of TDLUs and fat admix and the sort of sense of a circumscription a little bit, but that's something to consider for sure. Well, what do you see?
Who wants to discuss the case? Who wants to discuss the case?
I would think about microglandular adenosis.
Yeah, why do you think about microglandular adenosis? What is it you're seeing so that other people know?
There are these small glandular structures without myoepithelial layer, and there is this pink material inside.
Yeah, and it's very haphazard as well. It's just all over the place. Yeah, so this was a totally incidental finding in a case, and it was right by this lateral inferior margin here, and kind of cute. But yeah, so we have these small glands scattered in a haphazard pattern in the adipose tissue, with luminal secretions, as was mentioned. They often have bright eosinophilic secretions. And usually the epithelial cells look very bland, round, and monomorphic. And then there's no myoepithelial cell layer, which is totally bizarre for something that we're calling adenosis. But at present, we call this microglandular adenosis, although work from Eddie's institution is sort of questioning the whole, total benignity piece of it and whether it might be, a non-obligate precursor lesion, because we do see atypical forms and we do see forms associated with, triple negative cancers and other cancers, metaplastic carcinomas. So there's something unusual about it for sure. So that is one example of MGA. We have another one on coreneedle biopsy. So MGA, so if you had mistakenly called that as tubular carcinoma, do you want to say what would the ER, PR, and HER2 staining be for MGA?
Tubular carcinoma, I would expect a strong ER staining.
Yeah.
And in microglandular adenosis, negative.
Yeah, yeah. So that's right. So this would be one of those cases where if it's not staining as you would expect, say you had called this a low-grade invasive ductal carcinoma, as you might for this case, where you have small glands infiltrating the stroma in a haphazard pattern. So you could easily call this invasive ductal carcinoma. But if it came back as ER negative, then you should question the diagnosis, right? That doesn't make sense. And so they're strongly S100 positive, which is a positive sign that you can use to help with the diagnosis. This one has some atypical MGA. So most of the nests are small, round, sorry, most of the MGA is small, round glands, but some of them are starting to fill in. So once you start to see the glands filling in and forming solid nests, or that the glands start to coalesce and cribriform, then you need to sort of start worrying about atypical MGA. As we get down to this end here, you see they're starting to coalesce and fill in a little bit. And so I would call this atypical MGA at this end of the specimen. And Dr. Gravenstetter at your institution has written about, so again, this is one of these cases, potential pitfalls where you might call it a triple negative cancer. The patient might get chemotherapy, and this doesn't really, chemotherapy has no effect on the MGA component. It might treat, if there is a triple negative cancer associated with it, it might treat that, but the MGA seems to be unaffected by the chemotherapy. So this is just, it's not common. MGA is actually not common. We all, you know, love to try and make a diagnosis of it. And I know, you know, I've had trainees arrive, you know, with a diagnosis on the worksheet, and you know, oh, cool, it would be nice, but you know, usually it's not. So here's just another area where you see it's a little atypical. It's coalescing. Often has this cleared out cytoplasm as well. That's a characteristic feature of MGA as well. Yeah.
Sorry, I'm late.
Catching up.
About apocrine intraductal lesions.
Yeah.
Sometimes I find them difficult because I think you can rely only on cytological atypia, because ER won't help you because they are negative in hyperplasia and in DCIS. And also cytokeratins doesn't help you.
Yeah.
And so do you have some suggestions?
Yeah.
Sometimes I'm there, I say hyperplasia, also because in apocrine modifications, some atypia is given in the lesion, also in benign lesions.
Yeah. Yeah, I agree with you. It's very difficult to decide about atypia in apocrine proliferations. So I think, well, we all have a good handle on apocrine metaplasia, right? So you have lots of granular pink cytoplasm, round nuclei with prominent nucleoli, but usually the NC ratio is low. So I think when I start to worry, it's usually that the NC ratio is increasing. You've got a little bit less cytoplasm. You start to see some nuclear enlargement, but that's, you know, that's a judgment call. That's difficult to say. But it's really, then I begin on those lower grade end of the lesion. If it's not high, you know, high grade apocrine DCIS is easy, right? You can diagnose that. So it's on the low grade end of the spectrum. And so there, what I'm looking for is architectural atypia. So it's really once I start to see, you know, you're getting some cribriforming, you're getting much more papillary or micropapillary architecture, and more significant than just papillary apocrine change, which Eddie showed earlier. You really should have sort of cribriforming with polarization. I did have a case, I didn't bring it because I thought, you know, it wasn't a good example. The section wasn't very nice, but it was a case where the apocrine atypia was really quite subtle, and I almost thought of it as apocrine metaplasia in a papilloma. But there was something about the monotony and then starting to look and seeing, even though there was a lot of chatter in the section, you could sort of appreciate some efforts at cribber forming. And so I find I rely quite heavily on architecture, rigid architecture in that lower grade end of the spectrum. I don't know, do you have additional advice? Yeah. 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 So yeah.
Architecture is critical. I agree with the
Yeah. I mean, I think that's what you have to do. And then if it's in a Coreneedle biopsy, you know, I would just be careful and just say it's atypical and not call it DCIS. Wait till you have more. And that's what I did in this case that I was just describing, rather than showing you, where there was this sort of chatter. So the section wasn't good, but there was some sort of monotony and rigidity. And actually it did turn out to be apocrine DCIS on excision. So, you know, I think use your best judgment as best you can, and you have to go on the morphology and the architecture. So, all right. So this is, I think this is sort of a tricky case too. Let's see if I want to show you. I'm going to close this for a second because I want to get to the bit that's the trickiest bit. All right. Okay. So, oh dear, did I break it? No. Okay. So here, if we look on, this is a Coreneedle biopsy for you know, a mass lesion or something, image detected finding. And I think this is tricky because what does it look like we have here? And I'm going to lead you down the garden path, but how would you describe these sorts of areas? Yeah, it looks kind of lobular-centric, I think. So to begin with, I think a low power first look is sort of adenosis I'm thinking about, right? And, you know, even on higher power, you might think about adenosis. I guess one sort of thing that might, if you would just had these kind of areas, that might be a clue is it's sort of a little strange to have this normal duct in the middle, these normal ducts with these small glands around. That seems a little unusual to me. And then, you know, and then you start saying, oh, wait, actually, this is pretty atypical looking. Hang on, sorry, you need this condenser. So, you know, when you start to then look at the cytology, this is your normal epithelium, and this is your atypical epithelium. And then as you go back and look at low power again, you know, now it's sort of beyond those lobular-centric areas. You've got these nests just haphazardly growing throughout the core biopsy. But I actually thought on low power, I thought this was a tricky case. It was not my case, fortunately. But, you know, this area here, I don't know, is not so dissimilar to this area here. I think there's a certain lobular centricity to this particular growth of pattern of invasive carcinoma that I think could be a pitfall on that core biopsy. I think there was another core that it was, I don't know. Yeah, it's the same core. So, you know, there are areas where it does look more invasive. But I don't know. I thought, what do other people think? Do you think it's an easy miss? No, maybe not. You're all very sophisticated. That's what it is. So, well, immunostains were done for myoepithelial cells. But anyway, I just thought it was a nice case. A nice pitfall case. All right, let's see. I have, since we talked about this entity briefly. Oh, actually, you know what? I have the first. So I just do have a nice example of MGA with immunostains, I think. So here's an excision on a case. Trying to find more of the classic. Okay, up here is more of the sort of slightly more classic areas of MGA, although obviously this case has a lot of atypical MGA. And atypical MGA, you start to see a lot of apoptosis as well in the cells. Sorry, this one is a bit of an old case, so it's a bit faded. But I happen to have the, I think I have the, So here's our ER stain, right? So this is all ER negative in these infiltrating glands. And then this, I think, is the S100 stain. So just showing you how nicely S100 will stain MGA. Do have to be careful because S100 does stain normal ductal epithelium and invasive carcinomas too. But it's the sort of diffuse, strong staining that is most characteristic of MGA, as you have here. So that's just a little aside there of one with a stain. Returning to our other case that I was going to show you. Since we discussed this on one of our Coreneedle biopsies, and you can sort of see how if you just had a core biopsy through this entity, it could look like apocrine adenosis or atypical apocrine adenosis. I can very easily see that now. And this, does anybody want to hazard a guess? Yeah, this is secretory carcinoma. So kind of a microcystic pattern, but it also has, it often has this very sclerotic stroma with it as well. Tends to have, it's got luminal secretions as you would expect. Tends to have reasonably bland nuclei. So this one has a lot of hemorrhage in it. It's a really nice example, I think. How are we doing for time? Oh, I wanted to show. This is another differential diagnosis of small glandular proliferations. And this is an unusual, does anybody want to describe this? Actually, I'm going to start at this end. There are more classic areas of this particular entity, but if one of the trainees would like to just describe what you see. I'm not asking for a diagnosis necessarily, but I think it's a useful exercise to try and describe what you see.
Nobody? So that's small glandular structures which are clearing around.
Yeah.
So it's what's striking is this clearing of the cytoplasm.
Yeah.
So it seems biphasic.
Yeah, I would say it does look biphasic, right? So it looks like there's this layer of cells with clear cytoplasm, and then a layer of, sort of what we might say luminal layer of cells that have more eosinophilic cytoplasm. But they do seem to be small glandular structures otherwise. So, sorry? Yeah.
So it's this, it recalls me of epithelial myoepithelial carcinoma.
Yeah, so that could be a consideration, surely. Right. But this, well, what we ended up considering this as part of an atypical adenomyoepithelioma. So there was an area of a more lobulated mass. And so there's something like a tubular variant of adenomyoepithelioma where you have all these tubules that have both epithelial and myoepithelial cells. And honestly, it can be quite alarming because it can look quite infiltrative in through the stroma. And I guess, it's a good question. How would you decide about epithelial myoepithelial carcinoma versus tubular variant of adenomyoepithelioma? But I think, if you had sort of the more classic area without, with adenomyoepithelioma and demonstrated that these myoepithelial cells, determination of atypia, could be problematic. But I think in the end, we just categorize this as an atypical adenomyoepithelioma with a tubular component. No. Yeah. So But I think that's fairly unusual, that tubular component, and can be quite interesting to look at. Okay. I think, oh, and then the only other one I have to show you that I think is relevant is this, the one that I had shown in the slide presentation, or a similar one, which is another example of an adenomyoepithelioma where the pitfall is of calling it invasive carcinoma. This one was a bit funny because it had this sort of central area, which I don't really know. It was sort of almost histiocytoid and a little bit, yeah, it had these giant cells in it. I don't know what was going on here because I'm not aware of it having been biopsied before. But again, the differential or the question here was whether this was invasive carcinoma because of these irregular nests. But this actually turned out this was an adenomyoepithelioma as well. And you can sort of see the, you know, there's a circumscription to it at the edge that, you know, should cue you into the possibility of it not being an invasive carcinoma. And then, you know, you've got these myoepithelial cells and epithelial cells. So again, another biphasic kind of tumor, which you can highlight with immunostains if you need. I would add one little caveat that it's been my experience that adenomyoepitheliomas, you know, you might think you see a lot of myoepithelial cells, but they don't always stain exactly as you would imagine. You know, you'd expect it to be so strongly positive for P63 or smooth muscle myosin, heavy chain, or calponin. Doesn't always do that. And I think it's part of the myoepithelial cells being, you know, neoplastic or, you know, atypical, abnormal in some way, that they don't always stain exactly as you would expect. Shall we stop there? Any more questions?